assess or when you give them an intervention. So you need to consider about the safety for them. Then you need to examination for 3 levels, including functional task skill, for example, gait, sit to stand, reaching, and turning, that we will talk later. And then you need to consider about the essential strategy to complete tasks in various contexts. And then you need to consider about the underlying sensory, motor, cognitive impairments that constrain functional impairments. Okay? Then for the assessment is similar to the other neurological condition. For example, for stroke or for other movement disorder, including observation, I would like to remind you, Parkinson's disease quite have about the stoop posture. You know stoop posture, right? Yeah, back to the photo that I have attached. This is the typical posture that we have in PD. And you need to assess about musculoskeletal balance, sensory assessment, mental status, attention, medication, and activities of daily living. The star in muscle atrophy or muscle strength, I need to tell you that for the pathology of Parkinson's disease is not make the patient weakness, because it's not like stroke, it's not like the cortical spinal tract disorder, right? But almost of them found the weakness of their muscle because of its non-use. It's not about pathology, it's about non-use, or it's about reduce in physical activity. So almost of them always find the muscle weakness. So you need to keep in your mind, oh, maybe they have the weakness also. Yeah, so I think you guys may know about the principle for assessment. Then I would like to move on to the physiotherapy intervention for PD. You still go with me, right? Okay. Yeah, let's see about this diagram. This diagram tells you about the normal aging, the neuron gonna be damaged, their age. The loss of neuron without dopamine symptom is will longer than people who lost of dopamine. So you will see the neuron gonna be go to this graph, and then the some period of the time is will initiate sign and symptom. And yeah, Parkinson's disease is this type also. Then this period of time, you know my house, right? Periods of time, they still loss of dopamine, but we don't know about the loss or not because the sign and symptom not show yet. So if we know this earlier, we will maintain their function or slow the rate of progression of PD patient as long as we can. Okay? Yeah, so let's see this diagram. It kind of the same diagram that I talked. So this one is the sign and symptom show for the clinician. So if we know, and then we give them for the physiotherapy, and then they will live with Parkinson's disease long as they can, and this graph will be longer, okay? Because our goal for PD patient is we enhance and maintain their function, we improve participation of the patient, and we encourage the impairment mediation. So I mean to prevent impairment for the PD. Okay. Then I suggest this article is from Abruzzi. This is the Italian one, I think. Yeah, he conclusion about the rehabilitation of Parkinson's disease or of PD. And then it's quite good to follow them because they have the principle and they have the the suggestion of rehabilitation for PD. However, I have the conclusion for you guys also. Okay. For this, he suggests that training in Parkinson's disease needs to use cueing, even the visual cueing, auditory cueing, or verbal cueing. You know about cueing? Cueing is like an external signal for Parkinson's disease. For the visual cue is, for example, you need Parkinson to step forward longer, so you mark the tape or you mark the signal on the floor and then train Parkinson to touch that signal. Or you use the auditory cue. Auditory cue is when you use the metronome or some sound to trigger them for the movement. Or the verbal cue. Verbal cue is mean your sound. Parkinson's disease need the encouragement training. Then the article suggests movement training need to focus on gait and balance training, core exercise training, strength training, and flexibility training. And then they still suggest about the other therapy for Parkinson's disease. For example, aquatic therapy, dance therapy, or Tai Chi. You guys know Tai Chi? Does anybody try Tai Chi? Okay, I think some know. And then boxing, boxing, yeah. The article suggests boxing in Parkinson's disease is quite useful for improve their movement. But to be honest, I'm not try about this for training for Parkinson's disease yet, because I am like a exercise. I give exercise for individual patient, but this is like a plan for me to do the group therapy in Mahidol University. But we need to recruit the patient. We need to train about our physiotherapy, our physiotherapists in our clinic. And then if we setting about the group exercise, we will inform you later. Maybe you need to join us to come to see us, something like that. Okay. Then I would like to more details about movement strategy training. Yeah, the same article addresses tell us we need to know about goal-based learning. So you need to commitment with the participant, or you need to confirm with participant what the functional limitation or impairment that they want you to solve the problem. The second one, you give the treatment or exercise, you need to consider about intensity, frequency, specificity, and complexity. So we talked yesterday, this principle will make the patient with Parkinson's disease induce their brain plasticity, right? Yeah. Then they suggest aerobic training is appropriate for PD. In addition, we need to of cognitive impairment of Parkinson's disease. And then please keep in your mind, for the treatment or exercise that you will give to Parkinson's disease plan in advances, you need them to focus on the attention of tasks. So you need to treat them like a single track first. And then if they are familiar with your tasks, you can challenge them or progress the work, the tasks for them. And then break into parts. For example, if you need to train them to stand, you might need them to train about lean forward trunk first, and then you need to train the hip extensor, and then you combine about tasks to sit to stand. Yeah, Parkinson's disease is going to be trained like this. It will be easier for them. Then use the cue that I told you. The cue will help them in internal circuit impairment. They will trigger them to movement that you can. Okay. Yeah, that's the principle for physiotherapy. And then Margaret Chingman, I give her a name like the queen of Parkinson's disease. She suggests about exercise for each state of Parkinson's disease. Yeah, we always separate the PD patient with the early stages. Early stages is about Ho and Ya state 1 to 2.5. Mid stages is about 2.5, 3 or 4. And the later state is about 4 to 5. It depends on your PD patient that come to you. Okay? Yeah. For the early stages, Margaret Chingman, she advised your treatment or your exercise need to aim at high intensity. Endurance exercise is recommendation for these early stages, and consider about adding some particular symptoms, for example, about flexibility, balance exercise, or strengthening. And for the mid stages exercise or your treatment need to aim at moderate to high intensity. And the endurance exercise is still important. And then you need to give the treatment to Parkinson's disease in this stage with the tailored exercise. It means if you find the problem with the flexibility, so you need to give them the treatment for balance impairment, strengthening. So just see the case by case, okay? And for the later stages, Chengman suggests that intensity is not practical. However, we need to consider about intervention, other intervention for them also. For example, if they have they just stay on the wheelchair or just only bedridden, so you need to prevent their joint movement and their complication. Okay, right? Yeah, you guys maybe ask yourself, why is physiotherapy or exercise beneficial for Parkinson's disease? I have talked to you guys before, because it can induce brain plasticity in Parkinson. It will mapping in your brain, in their brain, and then it will improve their movement and live with Parkinson's disease patient. So there is an evidence to approve that exercise induces plasticity. Motor and cognitive circuits in Parkinson's disease improve. Yeah, this is neuroprotective is improved. BD and F serum improve, and yeah, sign symptom improve with training, and yeah, cortical motor excitability improve in Parkinson's disease. So I would tell you again, physiotherapy and exercise can slow the rate of progression of Parkinson's disease. Okay. So I would conclusion about the first section that I give you about the Parkinson's disease for physiotherapy. Parkinson's disease is recovery of the brain with exercise. Physiotherapy can boost PD performance like of individual goals and comorbidities. Exercise and intervention program needs to have enough repetition, intensity, and duration. And then the last one, exercise could impact the quality of life and can adapt to a feasibility outside the clinical setting. So choose with which exercise you do and who you exercise with. This one is quite, I like this concept because you can apply this to other patients and other neurological patients, right? Yeah, it's for me, I'm interested in turning deficits. So I will talk about turning deficit in the second part. You guys want to take a break before, or can I continue my lecture for now? Okay, I will continue my. Is it okay?
Yeah, please.
So I will talk about perspective of turning deficits in Parkinson's disease for physiotherapists. Why? Why I'm interested in turning deficits? Because turning deficits is increased for Parkinson's disease, and it's not sure yet, or it's not confirmed yet. Turning function is linked to postural instability, or postural instability is make turning deficits in PD. However, bradykinesia, the sensory impairment, postural dysfunction, it still impact to postural instability and turning dysfunction. So if you have your patient with PD, you might know about 60% with Parkinson's disease falls, and then it's increased their anxiety, it's increased their disability, increased their social isolation, and it's induced their physical activity. We have heard Dr. Shutima yesterday about physical activity. You can apply that to Parkinson's disease also. Okay? So let's see about turning. This is the normal turning in healthy adults. This video shows the normal turning. Can you guys see, right? Yeah. Okay. For the normal turning is segmental reorientation. It needs anticipatory saccades and nystagmus. And it needs head anticipatory. And the last one is need stepping characteristic. So I will talk more details about turning in healthy adults. So the first one is segmental reorientation. You know, turning function or turning is a process of coordination of the movement. Then the research found that when you're turning, the segmental is moved like a top-down sequence of body segment. It's the eye, followed by the head, the body, and the last one is the feet reorientation. If you see the research, they will always report like this. They always report with the onset latency with the body segment. Yeah, you see this, it begins with the eye, head, trunk, and the foot. Okay, and the second one, turning need the anticipatory saccades and nystagmus. Both are the eye movements, which we always report with the head movement in the research. So this graph say about the gaze. Gaze is mean head plus eye with the degree. And this is believed it represents an important part of the turning coordination process. If you see this graph, you will see gaze is start first, and then the head, and then the trunk, this one, and then the feet is the last one. Okay, but the third one is, I would like to tell you more about nystagmus. Nystagmus is the eye movement and is related to the vestibulo-ocular reflex. Okay, I remind you about vestibulo-ocular reflex, right? Yeah, it's about eye and head. So it's including about fast fade and slow fade. So the first one, fast fade or quick fade is move to the same direction of the turn. Fast fade is the same direction of the turn. So it represents the top-down sequence of coordination. And slow fade is the stabilized eye or stabilize the gaze by compensating with the head movement. For example, if the head turns to the left, this reflex for slow phase will move to the right. Yeah, doesn't matter. You might need to more understand about this, but just I want to tell you, eye movement is important for turning in healthy adults. Okay. Then the last coordination of turning is stepping characteristic. In humans, we found the stepping characteristic with two types. The first one is spin turn. Spin turn is strategy to turn towards by the momentum of the limb. And the step turn is strategy to use small step to provide the base of support. Can you guess about the healthy adults or about Parkinson's disease, which strategy that they use in their turning? Tick tock, which one? You guys right, it's the step turn because it provides about the more stability and more balance during turning. Okay, I hope you guys understand about the normal turning in healthy adults. Then I will move to the turning in Parkinson's disease. Okay, let's see about the turning in healthy adult again. They move with the eye, head, trunk, and then the stepping. Okay, so let's see about Parkinson's disease. The black circle because I would cover their face. I would not like you to recognize my patient. Okay. Yeah, this is 180 degrees turn. See, turning in Parkinson. You guys can try to turning 180 degrees now. How many steps you use? How many times you use? I guess you might use just only 1 or 2 steps, right? But for Parkinson, you see how many steps they use. Can you count it? Okay, and then this is another case that I have from my college. This is like a walking turn. See? Okay, would you like to see again? Yeah, you can try now how many steps that you use in 180 degrees or for 360 degrees. Yeah. So turning in Parkinson is turn with en bloc. You guys heard about en bloc? I would like to stop this one also. Okay. En bloc is defined as 2 criteria. The first one is moving or segmental together, and another one is a simultaneous of turning time of or segment reorientation. If you see that turn, they will move like a, how it's called, like a block, right? Yeah, it's like the block, but they call en bloc. Then they turn slower, they take more steps, and they use the narrower steps when compared with the healthy adults. Okay. So many research try to find about what the mechanism of turning deficits in PD. Then they try to find the eye to foot coordination, eye movement deficits, sequence and onset latency of coordination. They try to find kinematics and electromyography, and they try to find axial rotation is effect to the turning in Parkinson's disease or not. So this is my question in my research, my PhD also. What is the mechanism that underlie the turning problem in Parkinson's disease? So what my answer? Yeah, the possible mechanism of turning dysfunction and falling in PD is including the first one, head, neck, and trunk rigidity. The second one is bradykinesia. The third one is eye movement deficits. And the last one is gait disorder in PD. Okay, you can agree with me that is quite a possible mechanism. Okay, I will go with each topic. The first one is head, neck, and trunk rigidity. You guys may call it axial rigidity. Axial rigidity is resulting in reduced segment rotation and under the segment coordination and timing of turning. So imagine if you have the neck and trunk rigidity, it will increase neck and trunk extensor activity, and then it's entered about spatial temporal coordination of the axis. Okay. And the second one is bradykinesia. Bradykinesia is a failure of basal ganglia output to reinforce of the cortical mechanism that it prepare to initiate and executed movement. And it is believed is a potential causal mechanism for eye, head, and body coordination in PD during turning. Okay, the third one is eye movement problem. Some research provide the evidence that eye movement deficit in PD. For example, the degree to move the eye is less than normal people, or the onset latency is delayed when compared to the normal people. And this is affect their turning performance. And in addition, eye movement deficit is believed is the cause of turning on block in Parkinson's disease. Okay, and the last one, shuffling gait. You might heard this word, this gait disorder for Parkinson's disease, and another word is fascination gait. Okay, shuffling gait is mean the patient walk with the drag toe with the toe, I mean the toe of the foot, yeah, and then they use the small step and maybe fast step also. And this gait is lead to involuntary forward trunk lean. And then it's believed that it will lead the center of mass to shift forward, and it's believed that it's a constant state of postural instability of Parkinson's disease. So this is mechanism that I found in Parkinson's disease. So I solved the mechanism by my research also. Before go to my research, I will suggest to go with this intervention for PD patient. I have attached for you guys too many research that involve about turning in Parkinson's disease. It's since 1991 into 2020. So you can follow this exercise, and it might not only about turning, but it can improve gait also. So you can follow this intervention. Yeah, this one also. And then you can see about the parameter that you can take it in your clinic or in your research. Okay, and you can talk with me later if you interested in the intervention of turning. Then, for me, I believe the possible mechanism of turning in PD is come from head, neck, and trunk rigidity, and it's come from bradykinesia. So I want to solve to this problem of them. And this is my research in my PhD also. So how I can solve this problem? Okay, I construct a modified exercise program to improve about axial rigidity and turning dysfunction in PD. I apologize that I could not attach about this all of the research for you because it's still in the publication process. But however, if you want to talk to me later, you can email to me in the first slide that I attach my email to you also. But I will talk about this exercise as much as I can, okay? Yeah, I believe that axial deficit is lead to reduced segment rotation, is untouched about segment coordination and timing, and it lead to the secondary responses in the perpendicular segments during turning. So I think if I focus on the axial deficit, it will be improved about turning performance in PD. Okay. Before I construct the exercise, I have done a scoping review. You guys know a review, right? It's have the systematic review, it's have the meta-analysis, and I have done about the scoping review. Scoping review is quite scope to the topic that you want. Then I have done about this, but the process is the same of systematic review. However, I have done and included the study that focused on axial rigidity, just only 4 study. Okay? And 4 study is including the first one, Margaret Chengman. She improved the spinal flexibility and the 360 degree is improved. The second one is Bartolo. Bartolo is focused on the 4-week trunk-specific rehabilitation, and it can improve about axial deficit and turning also. The third one is Stosek. Stosek have the rehabilitation program, and it can improve about trunk rotation and turning 360 degrees. And the last one is power yoga. I haven't done it before, but yeah, this is quite good to improve the axial deficit, and it can improve the axial rotation and turning in PD. Okay, if you guys specialize in yoga program, you can give the Parkinson disease, but you need to be safety in both of you and patient also. Okay. Yeah, right. So I have modified about 4 study to my exercise program. However, it's always based on Chengman. It's the first study that I talk. Okay, my exercise is including stretching exercise, segmental rotation exercise, balance, and task specific. And then I use auditory cue plus the relax and maximum effort to my PD patient. So I have constructed my exercise with 2 groups like this. Yeah, I have 2 groups. The first one is exercise group. The second one is control group, and give the exercise for them for 4 weeks. And then measure about clinical abilities, turning kinematics, eye movement, and stepping characteristics. Then analyze the movement after that. So what I found? So I found my exercise program can improve the clinical abilities, including Unified Parkinson Disease Rating Scale, in total score, in motor score, and in rigidity score. You know, functional leash test, it for test the dynamic balance is improved. Force efficacy scale is improved, and rating of perceive is improved. Then turning kinematics, segment onset latency is improved. And the last one, stepping characteristic, including step size, total step, and step duration is improved also. Okay? So as I conclude in my study that reduced axial rigidity can improve whole body rotation of the body segment coordination. Okay, this is the story of my PhD, but before that, I have done about the turning in PD also. And I use the training big concept. May you guys know about the concept or not? No worries, I will talk about this also. And then I give them about the task specific concept to Parkinson disease. So my study in that moment, I have two groups them, and then I give them with this exercise, including breathing exercise, stretching exercise, alternate arm swing training, and balance training with the big concept. So big concept, and then I train them with the degree of turning. I separate in each degree for turning 180 degrees. And then my study found that the treatment of the treatment group is improved about turning step. And when compared for two groups, the treatment group is improved in turning step only. Okay, so you guys may, what is training big? What is called training big? What is confirmed? Yeah, it's not old for the training big, because in Parkinson, I think this concept is quite good to train them. It's not only about turning, it's about all movement that you want. Yeah, training big is come from the speech therapy. So, they try to teach patients with Parkinson to speak out loud, because they believe that sensory recalibration can teach the patient to recognize and accept the relationship between increased movement effort and normal motor output. So training big principle is focused on the hypokinetic and is the single attention, but you need to increase multiple repetitions. You need to consider the high intensity, and you need to increase complexity to your patient. Okay? So for the big concept, for the original of the paper, they compare about the home exercise, big exercise, and non-exercise, and test the walking. And they found that for the big group, is improved about the UPDRS, improve PDQ, Parkinson disease quality of life, improve the time up and go, and improve the 10 meters walk test. So it's quite good to use the big concept also. Yeah, in this presentation, I have attached you about the concept, original concept of training big to you guys also. So it's compare about speech therapy, Lee Silverman voice therapy, and it's applied to the movement. So you can compare and then take some message from the training book to teach your patient, right? Yeah, this one is the first, and then it have the second. Also, you can find by your own with the Fox in 2012, and you can read it and you will like it, because I always used it to train my Parkinson disease patient also. Okay, and I have attached about the exercise for Parkinson disease, and yeah, it's quite good to make to see the photo how they train with training big. Yeah, in here and in here. Okay, if you don't have time for now, I just remind you. You just think, if you don't feel like you are moving too big, you are not moving big enough. Okay, so it's remind you. You have to tell people, okay, your normal movement is like no, it's like 10 meters. So you have to tell Parkinson disease for 15 meters or something like that. You have to over for them because they are hypokinetic. Okay, so this is all of my presentation for now, and I would give you about Henry Ford quote: whether you think you can or you think you can't, you are right. It means we are physiotherapists. We can improve about the movement disorder, especially in Parkinson disease. They need to stay with PD as long as they can, and physiotherapists can help them to maintain their functional and maintain their performance in every aspect of their life. Okay? So I appreciate your attention and thank you for listening. See you again on the Q&A section, okay?
Thank you very much for Dr. Fuengfa. That's an interesting research. And there is Prof. Jarugool. Are you with us? Hello, Prof. Jarugool.
Hello, hello.
Okay.
Can you hear me?
Yes, of course. It's clear.
Okay.
Okay.
This is clear.
Yeah.
So may I get started?
Okay, I will read your CV first to introduce.
Oh, okay. Sure.
To our participant. Just a minute. Okay.
Okay.
Bapak Ibu sekalian, untuk pembicara kita selanjutnya adalah Associate Prof. Dr. Jarugool Tretriluxana. Beliau adalah Dekan Fakultas Fisioterapi Universitas Mahidol dan beliau menyelesaikan pendidikan bachelor di Mahidol University Thailand, lalu beliau menyelesaikan Master of Science Physiology di Mahidol University Thailand. Lalu beliau menyelesaikan Doctor of Philosophy Biokinesiology di University of Southern California, USA, and beliau menyelesaikan Doctor of Physical Therapy di University of Montana, USA. Beliau telah banyak diberikan penghargaan, banyak penghargaan, dan beliau tentu telah mempublish banyak sekali research, diantaranya tentang Transcranial Electromagnetic Stimulation yang hari ini akan dibawakan oleh beliau. Kalau saya harus membaca keseluruhan ini, sepertinya akan banyak memakan waktu karena panjang sekali ini CV-nya. Jadi kita langsung saja, dan untuk sesi Q&A, tanya jawab di akhir sesi, silakan letakkan pertanyaan Anda di kolom komentar, lalu gunakan tombol raise hand untuk, jadi ada tombol raise hand di situ. Nanti akan kami panggil siapa yang akan menyampaikan pertanyaannya langsung kepada pemateri kita. Jadi kalau Bapak Ibu mengklik tombol raise hand di sini, nanti muncul nama-nama Bapak Ibu sekalian di urutan paling atas. Nanti akan kami pilih sesuai dengan pertanyaan di kolom komentar yang kira-kira cukup mewakili pertanyaan dari teman-teman yang lain gitu. Oke, tidak perlu berlama-lama lagi, kita langsung we invite Prof. Jarugool Tretriluxana to present her presentation. For Prof. Jarugool, please.
Oh, thank you much. Even though I cannot understand what you say, but thank you for very nice introduction. Okay, so let me share my screen, right? Okay, can you all see my slide?
Yes, it's
okay.
Clear.
All right, so I will be using maybe 1.5 hours or so on to do 3 parts. Okay, so first I will give a little bit of background on the concept of transcranial magnetic stimulation. Okay, then followed by what are the in literatures that use transcranial magnetic stimulation, or we can use abbreviation as TMS. Okay, so how we could use TMS combined with task-specific training for regain upper extremity function after stroke. So it would be from literature, and mostly would be the finding from my laboratory at university, I mean at Mahidol University, okay? And then I would then explain about how we could expand the finding into some other population, right? So let me ask you all, so how much are you familiar with TMS? Anyone heard of TMS before? But let me tell you, so you heard a little bit about it. So what is it? So it's is one of the non-invasive neurological imaging method, okay, to study the brain activity, right? So let me introduce one, maybe it might be new to you, is called cortical spinal motor excitability, which means how much our cortex, or how much our central nervous system responds to TMS. Okay, right? So that's called cortical spinal excitability, right? So TMS is used the concept of changing the magnetic field, and then that can be used to stimulate our primary motor area, which then evoke the movement. The nice thing is it can measure the brain activity without any surgery, okay? Without any opening of your skull, without any external electrode putting on your brain, but it can measure, okay? But let me show you how it could be used. So TMS TMS based the concept on the concept of Faraday's law, which say that if you have two copper coils, which illustrate here, okay, and you put the electricity, it would then evoke another electromagnetic in the secondary coil. All right, so you put the current in we call it primary coil. It would then evoke another electricity in the secondary coil. So imagine if you place the coil on our primary motor area, then it would, what would happen? It would then evoke the movement, right, through cortical spinal tract. So that's the nice thing about TMS. So if we compare TMS with some other imaging technique, for example, functional MRI, PET scan, or CT scan, or EEG, right? So this illustration across all imaging technique, all right? So x-axis here illustrate, we call it spatial resolution. It means, are we measuring just one single cell, or we measuring cell column, or we measuring a whole brain, okay? So that's the x-axis. Y-axis here illustrate temporal resolution, meaning that are we seeing a response in a millisecond? Are we seeing a response in a second, in an hour, in a day, or in a year? Okay. All right. So let's just take a look at two dimension. So comparing to some other technique, TMS measure a brain activity at a cell column. So let me use this picture to illustrate what I mean by cell column. So this picture illustrates how many neurons. So this is illustrating primary motor area, this is pyramidal neurons along with interneurons. So if you place the TMS coil onto the primary motor area, it will evoke, it putting out a pulse, it putting out a pulse through one cell column. So it's not just one single cell, okay? It's cell column. So in the future, maybe a company come to you, okay, professor, I want to sell you a TMS machine which can stimulate one neuron. So don't trust them, okay? Because TMS at the moment can stimulate cell column, which composed of more than 10 cells. All right. So let me go back here. So as I said, if you compare TMS with some other technique, so I call it have intermediate spatial resolution, not one single cell, but it can measure cell column. Right. So let's take a look at temporal resolution. TMS, if you place the coil on the primary motor area, you can see the movement of the hand or of the big toe within millisecond. So it has very good temporal resolution, okay, better than functional MRI. So the way, but one thing that is different is TMS work in an opposite way of MRI, okay. With TMS, you place the TMS coil on our primary motor area, and then you will see a finger movement, and that is called interference. Okay, why in opposite functional MRI, you place your subject or your patient, a stroke patient, into the MRI scan. Then you ask your patient to move the finger, and then you will see the activation of the brain. You see that? So you move the finger first, and then you see the activation of the brain. This is called correlation. All right. So TMS works as interference, while MRI works as correlation. So it's work in the opposite direction. But if you ask about temporal resolution, you can see the activation of the brain in the MRI within seconds. So if someone asks you, you will say TMS has a better resolution in terms of temporal than functional MRI. Okay, so at this moment, I hope everyone on the same page. All right, so let me make a summary here. So TMS can measure at a cell column of the neurons, and it can evoke the response or the movement within millisecond. Okay, and if you take a look, is TMS becoming popular? Yes, you can see it as evidenced by the number of the paper that get published. So look at the slide here. This is already 10 years ago, right? But as you can see, TMS was founded in 1985. So if you ask me, Ajahn, Professor, how old is TMS? It's about 35 years ago, right? Or years old. So in that time, only a few papers get published on TMS. But as you can see here, this is 2015, right? You can see that thousands of papers get published on TMS. If you look, and if right now, I bet if you search on Google, you will see more than 2, 3, or even 5,000 papers on TMS. Why? Because it can be, one is not, as a physical therapist, I'm sure that we are able to use it, okay? Because we do have neuroanatomy knowledge, but you need some practice. For example, the student in my lab, they need to practice with me or with their classmate at least maybe 20 to 30 hours of practice, and they can use TMS. Besides the eases of the use, it can be used for diagnosis, and it can be used for prognosis, as well as, and we're going to talk about it today, is for therapeutic effect. Okay. So in terms of TMS has several modes, but I will be talking about repetitive mode this morning. Okay. Why? Because it is a mode that can be used as therapeutic effect, to be used to treat patients. And the nice thing about it is that, well, if someone asks you, what is repetitive TMS? You can say that it is TMS that have the frequency more than 0.3 hertz. Okay, within that you can classify it into two categories: low frequency, which is less than 1 hertz, and high frequency, which is more than 1 hertz. So what is nice about it is that the two categories have opposite effect on our cortical spinal tract. Okay, low frequency, which is less than 1 hertz, suppress, meaning that you're gonna suppress the brain activity, and in contrast, the high frequency enhance or increase cortical spinal excitability. Okay, so up till now, you are okay, clear? Can I hear any voice from you? You are still with me?
Okay.
Okay, all right. So good. All right. So with this, how could we use this opposite effect on our stroke? You think? You think we could use it for our stroke? I'm sure we can. Okay. So let's take a look at our brain first. Okay, the left picture illustrates our brain. We have two sides, right? Okay, the two sides communicate, and you can see that the size of the arrow seems equal, meaning that it have equal or we call it balance interaction between the two sides, right? But after someone got stroke, hopefully it's not us, huh? So this is the stroke brain. Okay, if this side have stroke, what would happen? It would have less influence, meaning that the good hemisphere will have a more impact, and you can see it have a bigger arrow. Okay, so the good hemisphere will send influence onto the damaged hemisphere, and unlucky, this influence is inhibition. So the good or the unaffected hemisphere send more inhibition onto the damaged hemisphere. And what bad about it? It lead to the poor function of the opposite hand. Okay, so that's also, so with TMS, how could we use it to help our stroke patient, you think? Here what we could do. Okay, we could either put the high frequency. Remember, the high frequency enhance cortical spinal excitability, right? So you could use the high frequency on the damaged hemisphere to upregulate. Okay, or you could use low frequency, okay, to suppress the good hemisphere so that it will disinhibit, let the bad or the damaged hemisphere work properly. Okay, so you are with me? So you could either use high frequency to stimulate the affected hemisphere, or you could use low frequency to inhibit the good hemisphere. Okay, use this framework. This is all the literature in the past, I would say like almost 20 years ago, that used low frequency, okay, to stimulate on the good hemisphere. And what do we care if we are physical therapists? We care if this stimulation could regain the hand or the arm function. Okay, and this is the list of all the reference, and you can search more nowadays that yes, if someone used low frequency TMS placing on the good hemisphere, it could improve motor function of the parodic hand. It could increase the pinch force. If you could induce thumb and hand adduction, you can improve hand function. And myself, for example, 10 years ago, show that low frequency TMS putting on the good hemisphere could improve reaching and grasping action. Oh, this is good. But you know what happened? The effect that I told you only lasts about 1 hour. Okay, so TMS about 20 minutes on the good hemisphere can improve hand function, but it lasts for about 1 hour. Okay, so as a physical therapist, what can we do? So it was again 12 years ago. I searched literature and found one literature. This is conducted in Japan. Okay, they ran a study, combined low frequency TMS on the good hemisphere. Okay, on the good hemisphere, combined with motor training like pinch training. So they have two conditions: real TMS combined with pinch training for 15 minutes, okay? And the control group is sham TMS, placebo TMS combined with pinch training. So what happened? With the real TMS combined with motor training, it can increase pinch force and acceleration of pinch, and that effect lasts for a week. Remember, I told you TMS by itself only lasts for 1 hour, okay? But when it combined with pinch training for 15 minutes, it lasts for a week. Wow, this is good, okay? And that's what was not seen in the control group. So this is the first study to give me and my group and my student motivation to continue the study. So one of my students 6-7 years ago come and ask me, Professor, I want to now train TMS with reaching and grasping training, okay, in chronic stroke. And this is what we did. So what we measure was cortical spinal excitability, so the brain, right? And we measure the behavior by Wolf motor function test and measure the movement time, okay? So this is what I call motor evoked potential, which means how much the brain responds or how much the brain get excitability respond to TMS. So the higher MEP or peak to peak amplitude represent the higher excitability of the brain, okay? So this is the two group, okay? We at that time we have chronic stroke, and there were two group: TMS, real TMS combined with reaching and grasping training, compared with sham TMS. So this is the way we did. So this is real TMS, the TMS placing on the good hemisphere, and this is the sham, which is placebo. Okay, so we tilt the coin 90 degrees. That means the pulse does not go to the brain; it's going to the air. Okay. So that means they did not get the TMS pulse, okay? So they get a TMS, whether it's real or sham, okay? And then we test, post-test, followed by reaching grasping training for 40 minutes. And we did post-test and 1 week follow-up. And this is the way we train. We do reaching and grasping training in a scheduled practice, okay? Train 5, rest 2 for 6 sessions. So a total of 42 minutes. And this is the characteristic of our patient, okay? So they are comparable, except they are comparable with everything, I'm sorry, okay? They are relatively chronic, and they are relatively mild to moderate stroke, measured by Fulgomer. Okay, first of all, we need to make sure that when we place TMS on the good hemisphere, we should see decrease in the MEP, right, of the good hemisphere, because we use low frequency. And that's what we found. We only see a reduction of MEP in the real, not in the sham group. So we're happy with that. So what happened with the hand? So as you can see here, we see a reduction in the movement time, and that lasts for a week, as well as the Wolf motor function. So this is the first study, okay, to combine low frequency TMS with reaching and grasping training. And this was done for stroke patients. So another one, so this is okay, as I said, okay. So our study extend the work of Japanese work, because they only did pinch training, but we did real world task, which is reaching and grasping training, and it lasts for a week. So my student come to me and, oh, Professor, we did the chronic stroke already, but we do know that the brain, if we started in earlier, it should last longer. Okay, so that's why we continue with subacute stroke in another the follow-up study. Same, we measure the same thing, but this time we stimulate for 20 minutes and we train task-specific training. Okay, so we did two things that is different. One is we measure, we give intervention earlier in subacute stroke, and we modify it into task-specific training. And with this intervention, we hypothesize that the effect would last longer. So it would last at least 2 weeks. That's why we measure a follow-up at 2 weeks. Okay. So we did same thing for TMS. Okay. But here we use constraint-induced movement therapy, and we also combine, we call it accelerated skill acquisition program. So what is it? Is this an intervention that based on task-specific training? It based on reducing impairment, and we let the patient collaborate with us in terms of task analysis, task progression. At that, then give them motivation to regain their movement. So this is what we train them based on task-specific training. So this is the characteristic, okay? As you can see here, they are relatively subacute, only 3 months post-stroke, okay? And relatively mild stroke. So this slide show you, first of all, when we apply TMS, we need to be sure that the TMS can suppress the cortical spinal excitability of the good hemisphere, okay? Evidenced by the negative number here, okay? As you can see here, after TMS, the brain get suppressed only in the active TMS, not the sham TMS, so that we are happy. So what do we care next? We care after the brain gets suppressed, do the parodic hand get better, right? So as you can see here, this graph show you the time of the parodic hand measured by Wolf motor function test. The negative number represent a reduction in the movement time, okay? Post 2 is immediately after the training. Post 3 was 1 week post training, and post 4 represent 2 weeks after the training. So what we see here, we see a reduction in the total movement time of Wolf motor function, only significantly in experimental group who received TMS combined with task-specific training, and the effect lasts at least 2 weeks. Okay, so we ask, oh, this is total movement time. So which specific task that they get better? So we did microanalysis on lifting a coke can. So one of the items was that we asked the patient to, okay, ready, set, go ahead and picking up a coke can, okay, and we measure the time. So as you can see here, the time bar that they perform picking up a coke can significantly reduced, and it lasts for at least 2 weeks. And that was only observed in the experimental group who received real TMS combined with task-specific training. Okay, so what's the take-home message here? The message here is that, oh, okay, we stimulate the brain, right? And we measure the hand. So what are the correlation here? So what we did further was we ran a correlation, okay, between the change in the brain and the change in the hand. And we see that we see a moderate correlation, okay, as you can see here, moderate correlation between only in the real TMS. So the reduction in the good hemisphere of the cortical spinal excitability have a moderate correlation with the improvement of the hand. So it can imply that there are correlation between the brain change and the improvement of the hand. Okay, so again, this was again the first study, okay, that illustrates that the combination of low frequency TMS that apply on the good hemisphere combined with task-specific training for 1 hour could improve sporadic hand function, and it lasts for about 2 weeks. Again, this is done in subacute stroke. Okay, so you can further, we take a look here at the YouTube. Okay, right? If you, I mean, you want to, can we try, or you want me to, you can do it later, or you want to take a look at this maybe a little bit? Okay, let me.
Okay. You want to open the video?
Yeah, please.
And it for you, or?
Yeah, so I put it in the chat. So could you open for me, please?
Okay, I will try to open and here.
Okay.
Wait a minute, it's still loading. Okay. Sure. Oke. Seperti ini.
From the statistic, we know that only about 30% of stroke patients would be able to regain their upper extremity function after they get stroke. So my motivation in the last 10 years is to improve their function. So that's why it gives me motivation to use the innovative intervention to help them. This research is about treating stroke patients using transcranial magnetic stimulation to augment the upper extremity training function in stroke patients. First of all, we need to know that stroke leads to the impairment of both lower extremity in terms of walking as well as upper limb function. For example, individual will not be able to eat, or they will not be able to get dressed themselves, or they will not be able to use the hand as usual. Actually, my motivation then would want to help them to regain their function. So basically we could use two approaches. One is to train them by training their hand themselves, or have them do activity, or you could then directly solve the brain problem. stimulation works in the same way as when you introduce the current into the copper coils. It would then introduce electricity. If you place the coil on the brain, it would then evoke the action potential, travel down through, we call it cortical spinal tract, and that would then evoke the movement in the hand. This transcranial magnetic stimulation is a non-invasive method. You place the coil and the patient just feeling like they're being tapped very gently, no pain. So if you only do brain stimulation, it lasts for only 1 hour. So that I was doing a lot of literature review and then decided to run more study, combine brain stimulation with motor training. Did brain stimulation combined with motor training is called task-specific training. And that would then extend it into last for 2 weeks. So meaning that instead of the patient coming every other day, they just come every 2 weeks. And that saves a lot of cost. This concept is based on the cognitive neuroscience. We have 3 components. First one is we call it task-specific trainings, meaning that we have the patient being trained of the task that they're having problem. The second one, we call it capacity. We want to minimize the impairment, and then that would then increase their capacity to move. And then the third component is called self-management. We want to engage their intrinsic drive by having them, first of all, pick the task that they would like to work on, analyzing the movement that they have problem, and have them involved in task progression. So as you can see that every single step they're being involved, so that if they face the problem in the future, they could then solve their own problem. And that would then maintain the function without physical therapist. More than 100 of patients that have been involved in our studies. The result came out that after they get training, brain stimulation for 20 minutes, combined with another 1.5 hours of task-specific training. So we were very happy with our study. And at the moment, we're trying to expand that into the real setting to our physical therapy center, so that the patient would get the real treatment from this intervention.
และอยากขอบคุณที่พัฒนาวิจัยการรักษาแล้วมีความหวังว่าจะหายค่ะ
I think would help the people around the world, since stroke is the leading cause of disability, actually one of the leading cause of disability. And I'm not just helping them, I'm helping their caregivers, I'm helping their family, I'm helping the country in terms of economic, actually quality of life of Thai population. From the statistics,
Yeah, Prof. You can unmute.
Okay, and then I continue with a little bit, just a few more slides, and then we could go. I think I will give a lot of time for Q&A session. I think because as I can see a lot of questions here. Okay, all right.
Yeah.
So as I mentioned in the YouTube, so this YouTube was our work in our lab was selected by Mahidol University to be on the Mahidol Research Impact. Okay, so it was a year, right? So as I mentioned that so can you see my slide?
there any problem, Prof?
Yeah, I'm trying to get back to the, let me see. I'm trying to getting back to the meeting to, let's see.
Oh.
Okay, let me see. Let's see.
Okay.
Let me try share again, okay?
Mm-hmm.
Can you see my slide?
Yeah.
You can see?
Yeah, I can see it's clear.
Okay, all right. So at the moment, we are confident actually with using TMS and task specific training for upper extremity, and we plan to expand it to our real service at our physical therapy center in Thailand sometime in the next few months. And we give real service to the patient. But what we're doing right now is to expand it to locomotion in like balance and standing and walking, as well as you can see here, mostly in the population that can gain benefit from TMS combined with task-specific training would be relatively mild to moderate stroke. Okay, so but as we know that mild to moderate will be about only 50% of the stroke patients. So that means we still have another 50% that cannot have benefit from task-specific training because they're not able to move their hand yet. So that's why what we are running study right now is to use TMS combined with ball bath technique. I think you're familiar with ball bath technique. So that's why we want to give more option to the severe patient. Okay. And also we want to expand it to some other population. For example, we did some study already for Parkinson's disease. Okay. And so we want to expand it to, for example, autistic spectrum disorder, because we do know that autistic spectrum disorder children system. Okay, they have problem with social interaction, for example. So what we plan right now is this was just publicized in Bangkok Post newspaper online just a few days ago, that we announced that we will expand it to autistic spectrum disorders. Okay, so what we want to share with you all right now is that TMS is itself is not that it's relatively new methodology, but it already 35 years old equipment. But you know, in order to say or to announce or some intervention, we want to make sure that we have evidence to support for that. So I want to say that with stroke, we have enough evidence to support, because we have done it for almost 12 years already, and it's have some benefits. And again, but combined with task-specific training is only for mild to moderate. So there's still more room that needs to be explored. Okay, so if I right now I think, but at least it's a good thing that I see some of the question from you, and I have some PhD student from Indonesia, because he mentioned that in Indonesia there's some hospital that already have TMS, right? I think. So I think it is now for you all to ask me questions, so I can give you some answer. If you have some uncertainty about TMS or some of the equipment or some of the intervention that I mentioned, I'm welcome to take questions. Thank you. So I see one question. Let's see.
Okay. Thank you very much, Prof. Jarugool and Dr. Fuengfa. And untuk peserta bisa ini masih ada yang Prof. Jarugool, there is something that you want to ask more?
There are questions, right? So I think the question, I saw 3 questions already. Let's go one by one.
Okay.
Is TMS, the question was, is TMS same as diathermy? No, it's not the same as diathermy.
Oh, okay. For the Q&A, we will move later, Prof.
Oh, okay. All right.
Okay.
Sorry.
Yeah. And untuk peserta, kita bisa aktifkan videonya sebentar untuk kita verifikasi peserta yang hadir sampai saat ini, ya. Diberikan waktu 2-3 menit ini untuk verifikasi. Jadi kalau nanti teman-teman ada yang ketinggalan absen misalnya, kita bisa verifikasi dari foto ini. Oke. Diaktifkan semuanya. Silakan Mbak Lina untuk di tag satu per layer ya. Prof. Jarugool and Dr. Fuengfa, please wait a minute. We will try to just take the photo of the participant for verification before we move to Q&A. Oke. Terima kasih untuk para peserta. Link absensi, Mbak Lina boleh link absensinya silakan di-share di chat room. Kemudian Bapak Ibu sekalian mulai dengan Q&A. Yang pertama kita mulai dari Oke. Bisa ya, kedengeran ya?
Ya.
Baik. Silakan untuk pertanyaannya. Videonya bisa diaktifkan dulu, Bu Satila.
Bisa nggak usah, Pak?
Oh, nggak usah. Oke.
Okay, thank you for my question is, could you give an example of how much frequency and intensity appropriate in exercise for every stage of PD and how to determine the dosage? There are 2 questions. The next question is, what is the reason you use auditory cue for your study? Is it better than another cueing? Example visual cue, like yang seperti yang dijelaskan tadi.
Baik. Oke. Prof. Fuengfa. Dr. Fuengfa. Oke. Wait a minute. Please unmute first. Yeah. Okay,
Right.
please.
Yeah, for the first question that you would me to give an example of the dose of training in Parkinson's disease, I would prefer the reference to ACSM for the guideline exercise and testing and prescription in Parkinson's disease. They suggest that you should do the aerobic exercise at least 2 or 3 times a week. And for stretching, you should do 20 or 30 seconds. And I take this information to my research also. And then I suggest about the dose or repetition. If you look back to the principle of neuroplasticity, for the monkey, they would do about 300 times repetition and 2 times. And Parkinson's disease is have many factors to their condition. And then I ask about the original of exercise. It suggests that we need to monitor at least 10 repetition first, and then can increase to 20 times and 20 repetition, and then let's see how learning they are. So you can increase your challenge for more, depend on your condition of the patient, but is check it. It will let them move better than the first time that you meet the patient. And for the second question is why I use the auditory cue in my thesis. Because in one article, they show that auditory cue can engage the PD patient better in rolling or in rotational. So I take the auditory cue in my thesis. But if you use visual cue, it's not wrong. I suggest also, especially in walking, it's quite easy that your patient will be follow the cue. However, think about you can use one of those. Don't mix it together. If you mix it, your Parkinson's disease is going to be confused and it's not good to the patient. Is it okay for this question?
Okay.
Okay, thank you for Dr. from answer. And then the next question is from Mr. Andung. From Mr. Andung. Wait a minute. Andung, Pak Andung bisa dengar? Pak Andung bisa dengar saya? Oke.
Ya.
Silakan Pak Andung.
Ya, jadi morning Dr. Fuengfa and Prof. Jarugool. I want to question with the Parkinson disease. In the Parkinson disease, we have a lost coordination for the movement. And what the Transcranial exercise can apply to the Parkinson problem? And then the second is how long the Parkinson disease have a good movement to the coordination for the Parkinson disease problem. And then for Prof. Jarugool, I want to question about the...
Pak Andung mungkin ke Dr. Fuengfa dulu, nanti kita ke berikutnya untuk Pak Jarugool. Ya.
Ya, terima kasih.
Please, Dr. Fuengfa.
Okay. For the first question is, what about the Frankel exercise to Parkinson's disease? In my opinion, Frankel exercise is for the coordination training with about, especially in ataxia people, ataxia patient, that is pathological from cerebella. And then would we use the fungal exercise to Parkinson's disease or not? I have found one study that they investigate about fungal exercise in Parkinson's disease. But however, you need to assess your patient that they have the coordination deficits or not. I mean, it needs to be deficit kind of the ataxia movement or something, because in terms of Parkinson's disease, their coordination may be deficit, but it's not weakness, it's not from the pure coordination pathology. So you need to assess them that they have this dysfunction or not. If it is, you can use it, or you can, whatever that you want, and then you have to recheck it can improve the movement or not. And how long for training about coordination? In my experience, if you give them the direct impairments, it's just one time that they are with you. I mean, one session, 60 minutes, you will see the improvement of the coordination of the patient. And Dr. Jarugool, would you suggest something about fungal exercise or not?
Okay.
Okay. Well, I agree with Professor Fuengfa in terms of so I think it depends on the severity of the patients. So it can be used if the impairment is about coordination. Okay, but as Dr. Fuengfa mentioned, the prominent impairment or the cardinal sign of Parkinson's disease is bradykinesia. So I think we need to focus more on to regain movement speed and movement amplitude more than coordination, in my opinion. Thank you.
Thank you for the answer for Prof. Jarugool and Dr. Fuengfa. The next the question for Prof. Jarugool. Silahkan atas nama Ibu Ruri Kistiantari. Bu Ruri, bisa mendengarkan saya?
Hai. Ya, bisa.
Oke, silahkan Bu.
Ya. Hi, Prof. Jarugool. Actually, I was lost of signal and I lost a lot of your lecture, but I have a question for you. If that you ever do this TMS to other disease, like the same disorder like stroke, and what the progress that you had, and what the disease is it? That's all. Thank you.
Okay, please.
Okay, I'm trying to unmute myself. All right, so the question was, have I used TMS for some other musculoskeletal, right? MS?
Yes.
MS means
yes.
not multiple sclerosis. Oh, you mean MS means?
I mean this, that you ever have this TMS to the other disease like stroke, but the same disorder like stroke. What the disease is it, and what the progress about it?
Oh, okay, so if you ask me myself, we have used it for Parkinson's and autistic spectrum disorder.
Yeah.
Okay, Parkinson's disease, you need, as I mentioned in my lecture, that for stroke, myself, I use low frequency apply to the good hemisphere, right? But some other people can use high frequency apply on the affected hemisphere and the effect was comparable. In terms of Parkinson's disease, we need to use also high frequency also. The effect may not be as good as stroke because the pathology is different. So you need more number of sessions in Parkinson's disease. Okay. For autistic, we are still working on it, right? But but if you look at review literature in the past 15 years, TMS has been proved to help depression, Alzheimer's disease, okay, pain, okay, neglect, aphasia for stroke. So it has been used for research. But if you ask me for real practical setting, it can be used for depression, and it's already been approved by FDA in the US to use for depression. Okay, but for stroke, private hospital, people, physician and physical therapy started to use it in the private hospital already.
Okay.
Yes.
Oh yeah. Actually, it's the same like me because we don't have it yet. So I wish that I can have it maybe someday.
Right, but let me share with you. It is costly, okay, if you purchase it from the original country like US, UK, or Denmark. The machine will be relatively expensive, but it's less expensive than MRI.
Okay, yeah.
Okay,
yeah,
but nowadays there are machines from Korea, Japan. Yeah, that is cheaper. So that you need to look in the market, and I'm sure China can make it soon. So so look into the market. It's getting cheaper, I think.
Okay, thank you very much.
Very much for Prof. Jarugool and kepada Bu Glory, terima kasih. Kemudian pertanyaan berikutnya dari Pak Abdul Khalik Maidian. Pak Maidian, bisa mendengarkan saya? Pak Maidian bisa mendengarkan saya?
Yeah, hello. Can you hear me?
Oke. Ya.
Okay.
Silakan Pak Maidian.
Okay, thank you very much for your presentation. It's very great information for us. So I want to ask to the first presenter, Professor Khobkhun. So my question is about. Please wait. What my question is?
Suaranya bisa lebih keras lagi Pak Maidian. Terdengar kecil di sini.
Please wait.
Okay.
I'm searching my question. Where is my question? This one. Okay, my question is about the how the profile of visual attention in Parkinson disease. Is there any literature that has explained related to this issue? I mean, for the Parkinson disease, how about the visual direction or visual attentions, or that affect their mobility for walking or for standing, etc. This is my first question. My second question for Professor Jarugool. Is possible to ask together now?
Ya, silakan.
My second question about the rTMS. What is the effectiveness of using rTMS in the station with USN based on the functional outcome measure? Have you any evidence to explain about it? Thank you very much.
Okay, thank you very much for Mr. Abdul Khalik Maidian. Okay, please, Dr. Fuengfa and Prof. Jarugool. The first for Prof. Jarugool to answer, maybe. Yeah.
For me.
Hello.
So you want me to go first, or Professor.
Yeah, the Prof. Jarugool can answer first. Answer the question first about the effectiveness of using rTMS in stroke patient with unilateral special neglect based on function outcome measure. There are some literature or something like that.
Okay, right. So the question was about the effectiveness of TMS for neglect, right?
Right.
Okay. Yeah. Yes. Yes. The literature have used TMS for neglect. Yes.
So
There's some evidence for that. Yes.
yeah. So how about the effectiveness?
Effectiveness.
On
So,
the
but well, it have been used only for TMS. But if you ask me personally, as a physical therapist, I think, and the physiological of TMS, TMS alone long. So you need to either use several sessions, or you can use TMS combined with training for neglect. Yeah. So if you ask me for suggestion, I would suggest TMS combined with some as our technique that we use. You know, because TMS is very costly. So I'm suggesting you to think about cost effectiveness as well.
So no the use of FNS combined with the other exercise in the application.
Yes. In Thailand, in my university, we have proof that we use TMS combined with some other technique.
Oh, okay. Thank you very much for
very
your
much
answer.
Sure.
for the answer. Next for Dr. Fuengfa, please.
Okay, you asked me about visual attention training. Yes, there are some study that is training with the visual selective attention. I think it's from New Zealand, Otago University. You can look back to the literature, and it's approved that if you training about visual attention, Parkinson disease will improve about motor coordination or whatever that study improve. But you need to select the patient that the visual attention need to be exclude about the hallucination, exclude about eye movement deficit first, and see the effect of the attention. And I think it would be good if you train with the visual attention also with the performance.
Okay. Thank you very much for
Thank
your
you very much.
answer.
Is it clear, Mr. Abdul Khalik?
Yeah, it's okay. Thank you very much.
Okay, thank you very much. Okay, the next question for Prof. Jarugool from Mira Hafiza. Mira Hafiza? Mira Hafiza, bisa dengar saya?
Yes.
Okay.
Can you hear my voice?
Yes, that's clear. Please.
Okay. Good morning, Prof. Jarugool and Prof. Fuengfa. Thank you for the opportunity. The first question is for Prof. Fuengfa. After the final goal on PD patients is achieved, what can we do next? Do PD patients keep doing their PT for maintenance, or can they
follow up them for measure about their performance later? If they decrease something, you can add on it. You can, but I suggest to tell them to exercise in all their life to maintain their function. Would not stop for it. Okay?
Okay. In your experience, can they be independent for doing their activity daily living?
Yeah, to be honest, I work in physiotherapy faculty for 3 years, and then they still with me 1 year, and I left for education in the UK, and then I give them with other physiotherapists. And when I come back from the UK, I still can see them, but the progression is worse. I'm not sure it might be any factors that disturb them. You know, it's not about only Parkinson disease. They might have the comorbidities, and when they're back to home, they're not exercise. They just only want PT to exercise. It depends on the factors of personal factor also. And then I have seen the question, what about the home-based exercise? It's quite important and it's quite necessary for Parkinson's disease. And I just got the scholarship for do the home-based exercise for Parkinson's disease. And if it's achieved for home-based exercise in my research, I will provide the exercise for Parkinson's disease at home also. Okay.
I think the environmental is also have a big influence for the patients also. Yes. Okay, thank you, Prof. Fuengfa.
Thank you. And for the next question for Prof. Jarugool, please, Prof. Jarugool.
Okay, I think you asked me 2 questions. So what's the best time to apply TMS? So I think the best time is to the earlier is the better. Okay. Okay. But let me
after yeah. Okay.
Yeah, but from evidence you need to give TMS before physical therapy. So the order should be TMS followed by physical therapy, because TMS is used to prime the system to wake up the cortical spinal excitability. Okay, could be, and you asked me the second question whether the chronic stroke can have benefit. Yes, because we have done that and show that. Okay, that but again, the retention of the effectiveness depends on number of sessions that you give. Okay, so at least you need more than 1 session if you want it to last longer. All right, but let me tell you all about one thing before you decided to use TMS. It is not for everyone. It got contraindication for someone who has history of seizure, okay, someone who have metal in the brain or the area that you want to stimulate, because TMS can be used to stimulate at brainstem or spinal cord also. All right, so the contraindication again, history of seizure, metal implant in the area that you want to stimulate, and someone who wear pacemaker. Just so you know.
How about tumor in the brain? Is that one of
tumor is not contra, but it's precaution. Okay.
Thank you very much for Prof. Jarugool dan Bu Mira. Terima kasih untuk
waktunya.
Kemudian next question from Savitri Febriani. Savitri Febriani, can you hear me? Hello, Savitri Febriani. Okay, can you hear me? Okay, no. Ada? Maybe I will read her question for you, because her voice not here. As we know, there are different methods of the physical therapy treatment for stroke patient. So how much differences how different it could be to improve the brain excitability between TMS and task-specific training and other physical therapy treatment? Thank you.
Okay, so you asked about the evidence for other intervention besides task-specific training to induce.
But how much the difference?
How much the difference? Okay. Yeah. So we have tried several, meaning that we have tried. I call it usual care. Usual care means what we do as usual. Okay, range of motion, strengthening exercise, something like that. Is not effective as task-specific training if you combine with TMS. Okay. But again, it depends. If someone who cannot move, you cannot use task-specific training. You want to do something else, like range of motion exercise. So I think it very much depends on the severity of the patients. But if you ask me about mild to moderate severity, task-specific training have strong evidence to show that it lasts longer and is more effective. Did I answer your question?
Thank you very much. Safitri sudah terjawab ya? Okay. For the next question from Miss Nia Kurniawati. Miss Nia, can you hear me? Hello, Miss Nia, can you hear me? Okay, can you hear me?
Okay. Yes. Yeah. Sorry. Hello.
Okay. Ya, silakan Bu Nia.
Okay. Thank you, Mr. Arul. Thank you for your opportunity for me. I want to ask to Prof. Jarugool. How about the physiological evidence in synaptic plasticity mechanism on brain after specific training with LF-rTMS, and how effectiveness for spastic patient? Spasticity, yeah. Okay. For Prof. Fuengfa, what your experience about dual task training program about motor and executive function like balance and memory training combined for PD? Okay, thank you, Mr. Arul.
Okay, thank you
Hello.
for the question. Okay, first answer from Prof. Jarugool, please.
Okay. Yes, good question. Very physiological question. Yes, low frequency TMS has been proved to actually work through long-term depression and long-term potentiation. If you ask about physiological effect, it induces GABAergic neurotransmitter. That's why it can suppress cortical spinal excitability. So the answer for your first question was yes. Okay. Second question is about effectiveness for spasticity. Yes. Okay. So there are evidence to show, you can look it up since 2008, that it can be done to reduce spasticity. Okay. But that paper used both frequency, meaning that you need to apply high frequency on the affected hemisphere combined with low frequency on the good hemisphere, and that could reduce spasticity. Yes.
Oh, okay. How about the dosage?
Dosage. Okay.
Of
right. So at that paper, at least 6 sessions. So you need to try. I think if you want to try, you can try 6 to 12 sessions of TMS, or you could try combine with the technique that we use as a physical therapy. Okay, and that, I think that could reduce the number of sessions.
Can we apply for the other problem, maybe gait or sit to stand or another problem, not only on hand?
Yeah, well, the literature I have done for locomotion, yes, but I have not seen TMS combined with task-specific training yet. That's why we are running study on that. Okay.
Oh, okay.
But based on neuroanatomy, you need different coil for hand. Well, I'm sorry, for leg muscle though. Okay. There are several types of coil depending on body homunculus on the primary motor area.
Okay, okay.
So with
Thank you,
hand
Prof.
muscle, yeah, with hand muscle you use figure of 8 coil. With leg muscle you need double cone coil.
Oh, okay.
Thank you for the
Okay,
answer.
thank you.
Is it clear for the first question?
Okay, thank you.
Okay. The next for Dr. Fuengfa,
Okay.
please.
Yeah, I had an experience for do a task training program for PD patient. Yeah, but I would tell you it depends on the severity of PD. I have trained all tasks with the early stages. Yeah, is get training without count the number. It's work in some period of the session, and yeah, I follow up, and it still work in early stages. But for mid stage, it make them confused too much, and then when they count the number, step gonna be shorter. So I have to give up that dual talks for middle to later stage. So it depends on your severity, and when you test it at first, it works, so you can continue. But I still suggest to make it easy and let them to focus on the single attention, and if them do easy complexity. So first.
Okay, thank you. For cognitive problem in PD, how about your experience?
Yes, I have one case that he got the mild cognitive, and then 3 years later he got the Alzheimer. So yeah, it's the question that PD is lead to Alzheimer or Alzheimer lead to PD, and they used before, and yeah, whatever. So you need to. But in the research, they suggest to training the cognitive also, because it's gonna have the brain plasticity to them, and then it will engage about motor performance also.
Okay.
Okay, thank
Thank you,
you.
Prof.
Clear, Miss Nia?
Yes, clear. Thank you.
Okay.
Yeah.
Thank you very much for the answer, Dr. Fuengfa. And the last question from Mr. Andung. Pak Andung, tadi masih ada pertanyaan yang tersisa ya. Pak Andung bisa mendengar saya?
Yeah.
Okay. Last question for Prof. Jarugool. Okay, please.
My question is about the modality for the TMS. Is the same of our hospital have a short wave or micro diathermy that can apply with our patient? This is the same with diathermy for TMS. Thank you.
Yeah, I think
Please.
yes. Okay, you asked about diathermy, right?
Yes.
Yeah.
Yeah.
Well, no, very good question. I got this question last month as well from a clinician in Thailand, because I think this diathermy has been used a lot, quite a bit. So I have not have experience use diathermy, but I look it up in their manual. It is not the same. Okay, diathermy mostly used for wound healing, and it used the effect of vasodilatation. So it doesn't work the same way at all. Okay, so TMS work through induced electromagnetic system that can induce. The answer is no.
Okay. The effect is the difference, right?
Different.
Okay.
Cheaper.
Clear,
Diathermy
Pak
cheaper.
Andung? Okay.
Yes.
Clear, Pak Andung? Oke. Baik. Itu semua pertanyaan yang sudah disampaikan. That's all the question that we got from our participant, and then I think it's enough for today. Thank you very much for our speaker today, Dr. Fuengfa and Prof. Jarugool. Thank you very much. It's an honor for me to be your moderator. And untuk partisipan, untuk peserta, mohon untuk pastikan bahwa Anda telah mengisi link absensi yang telah kami berikan di kolom komentar kolom chat. Jadi kalau pun tidak lupa untuk mengisinya, Anda diharuskan untuk memiliki bukti valid untuk meyakinkan bahwa Anda telah mengikuti seluruh rangkaian webinar ini. Karena di sini saya lihat ada sekitar 166 orang yang dari tadi 180 sekian orang, artinya ada beberapa orang yang sudah keluar setelah mengisi absen. Saya akan melakukan verifikasi kembali untuk peserta yang masih tetap bertahan sampai sekarang. Mbak Lina, bisa dengar saya? Mana Mbak Lina? Oke, bersiap untuk kita verifikasi ya. Jadi tolong diaktifkan kembali kameranya agar kita bisa memverifikasi. Silakan aktifkan kembali ya untuk Bapak Ibu sekalian. Oke, saya mulai.
Thank you for all speakers for your willingness to give their usable material on this day. Dan juga untuk para peserta yang sudah mengirimkan audio itu maupun so untuk
Jadi kita masih ada 165 peserta di sini yang masih bertahan. Nah, terakhir. Oke. Baik Bapak Ibu sekalian, kami telah melakukan verifikasi untuk setiap peserta yang masuk. Terima kasih untuk telah bergabung bersama kami dari awal sampai akhir. Semoga ilmu yang Bapak Ibu terima semua pada hari ini bermanfaat, dan jangan lupa untuk besok masih ada satu sesi lagi, dan satu sesi yang terakhir akan banyak diisi dengan diskusi dan diisi oleh Pak Irfan. Pak Irfan akan sedikit merangkum beberapa topik yang telah disampaikan dan akan akan banyak dilakukan diskusi. Maka silakan persiapkan pertanyaan-pertanyaan yang ingin Anda tanyakan tentang materi yang telah dilangsungkan selama 2 hari ini, akan kita diskusikan di hari ketiga. Oke. Saya sebagai moderator undur diri, saya kembalikan kepada host. Silakan.
Baik, terima kasih Pak Rul. Thank you for all speaker are willing to give us this very usable material on this day. Dan juga untuk para peserta yang sudah mengikuti webinar ini melalui Zoom meeting maupun live streaming Facebook dan YouTube. Demikian rangkaian acara webinar kita hari ini, akan dilanjutkan besok pada tanggal dan pukul yang sudah ditentukan. Maka kami akhiri webinar pada hari ini dengan mengucapkan kafaratul majlis. Saya selaku MC pamit undur diri. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Okay, thank you very much for Prof. Jarugool, Prof. Dr. Fuengfa.
Thank you very much for all.
Time today.
Nice meeting you all.
Bye, guys.
Bye.
Thank you, Acha.
Terima kasih untuk serta. Ingat untuk besok kita akan mulai malam jam 7 ya.
Thank you. Iya,
Kan standby sebelum itu lakukan masuk. Dan mohon maaf untuk gangguan teknis yang tadi dirasakan oleh teman-teman. Semoga besok tidak terulang kembali. Terima kasih banyak.